Welcome everyone. My name is Lou Irving and this is the final session, and I'd like to congratulate the organisers of the meeting for leaving the best to last. We have three wonderful speeches on topics that are quite diverse. The first is on monkeypox. The second is on how to communicate risk, particularly about COVID vaccination. And the third, talk about aids to allow children to more easily accept vaccination, to distract them. So the first talk is on monkeypox. It's by a colleague of mine, Dr. Kasia Singh, who works at Royal Melbourne Hospital. Kasia is an incredibly experienced infectious diseases specialist across a range of subtopics in infectious diseases, and she's ideally suited to update us on monkeypox. Kasia, I'm looking forward to the talk.
Thanks for the opportunity to speak today on monkeypox. Everyone, I think, will be aware that since early May 2022, monkeypox infections have been reported from a number of countries in which they have not previously been reported without travel history or at all. The Emergency Committee at the World Health Organization declared an outbreak of monkeypox as a public health emergency of international concern at their meeting on the 21st of July. Partly this was to help facilitate a coordinated response to the unprecedented rapid spread and to try and help us understand what might have been happening. Cases of monkeypox have now been reported to the World Health Organization from, I think it's now 90 member states across all 6 World Health Organization regions. And you can see here some of the detailed case report numbers that have been received to compile a bit of a picture of what we might be seeing. But just to add here, these are the top 10 countries in terms of cumulative cases, and the notification rates in some of them may be on a slightly downward trend, although that remains to be confirmed. And just to mention that the axes here have slightly different numbers, so they're not comparable axes in all cases. Most of them, as you can see, are in Europe and North America. So since the 13th of May, and this is an outbreak map from the CDC, a high proportion of the cases, as I mentioned, have been reported from countries without previously documented transmission. This map represents over 40,000 cases, and in orange are locations where monkeypox has not previously been reported in these sort of numbers. It's the first time that cases in sustained transmission have been reported in countries without direct or immediate epidemiological links to areas of West or Central Africa. At the moment, confirmation of one case of monkeypox in a country is considered to be an outbreak. So what about local epidemiology? Up until Friday, the 19th of August, we have had 40 cases in Victoria, 12 of which are active. All at the moment have been in metropolitan Melbourne. 20 overseas acquired, 1 interstate, and 16 were locally transmitted. 100% of cases so far are in men with a median age of 37, and all have had history of MSM contact. There has been suspected transmission at sex on premises venues and events, but this is all, as you can imagine, still under investigation. So one of the things I wanted to mention was this foreseen? At the time this occurred, it created a large amount of discussion in the media, and this unexpected appearance of monkeypox in several regions without obvious links to West or Central Africa suggests that there may have been some undetected transmission going on for a while. Certainly with the eradication of smallpox in 1980 and subsequent cessation of the smallpox vaccine, there was concern among groups that monkeypox might emerge as an important orthopox virus for public health. More recently, an increase in cases had certainly been noticed, and the discovery of monkeypox cases in countries where it hadn't traditionally been seen previously. The increase in numbers, in particular in Congo and Nigeria, had been notable and reported on. A word on nomenclature. Many of you will recall the issues around renaming of what was originally referred to as the Wuhan virus to SARS-CoV-2. In a similar, although somewhat belated fashion, work's in progress at the moment to rename monkeypox. The World Health Organization is currently actually accepting suggestions for new names. Renaming of the clades has already been undertaken, with clade 1 and 2 replacing what were previously referred to as the Congo Basin and West African clades. Subclades of 2 are also recognised. These are the orthopox viruses you can see amongst the double-stranded DNA viruses, along with herpes viruses over here. They're a genus of enveloped double-stranded DNA viruses, and they infect both humans and animals, with the best known member being variola virus, which causes smallpox. Other members include vaccinia, camelpox, cowpox, horsepox, skunkpox, and a number of other pox viruses. For the one we're currently concerned about, so-called monkeypox, the natural or host reservoir is not actually known. We know that numerous species are susceptible, including various different kinds of rodents and non-human primates. A recent reported transmission to a dog exists, and certainly in the US, a previous outbreak was associated with prairie dogs. The timeline up to 2010 of monkeypox virus is illustrated on here. It was first isolated from skin lesions on an imported macaque in a Danish lab in 1958 and was known to cause outbreaks in captive primates, with the first human case reported in 1970 from the DRC. Human infections with monkeypox virus result in a disease that closely resembles discrete or ordinary smallpox. It's thought that this may have obscured earlier appreciation of the disease's existence prior to the recognition in 1970. This recognition coincided or came to light during intensive smallpox eradication programs in West and Central Africa, when rigorous lab investigations of lingering cases were being pursued. In the boxes at the top of this are countries with reported outbreaks and or cases by decade to 2010. By number, most from the DRC and bordering countries, such as Cameroon and later on Sudan. The human disease is either unapparent or absent from those areas of West Africa from which cases were identified in the 70s and 80s. In 2003, the first cases detected outside of Africa were found in the USA and were traced to importation of wild West African rodents from Ghana, confirming the virus had not been extinct in that region despite no human cases being reported. In both Ghana and the Republic of Congo, small-scale serosurveys revealed anti-orthopox virus seroprevalence rates of between 40 and 50% amongst those less than 25 who live around the forest margins. This slide was shown during the recent IAS AIDS conference in Montreal by Dimi Ogona from Niger Delta University, showing the traditional or where the monkeypox virus cases were first recognised around this region, around the river and the rainforest belt of Congo going into West Africa. What about since 2010? Since 2010, there's certainly been increasing recognition of cases amongst locations within Africa. Here represented is the Nigerian outbreak from 2017 that we already referred to earlier. Cases outside of Africa associated with travel from Nigeria have also been recognised over the last 5 years, including to Israel, the UK, Singapore and USA, with some associated, although limited, onward transmission to household or healthcare worker contacts. Earlier this year, on May the 7th, the UK Health Security Agency announced a confirmed monkeypox case in a traveller returning from Nigeria, and shortly afterwards, a second and then a third unrelated cluster of cases were also recognised. The third involved 4 cases identified at a sexual health clinic and involved people who identify as gay, bisexual or MSM. At around the same time, a traveller returning to New York City was evaluated for an oral lesion and a new painful perianal rash. And another traveller very shortly afterwards was diagnosed, and these were confirmed as monkeypox a couple of weeks later. It is worth mentioning that over this time, in addition to increasing numbers in Africa, there was also a change being seen in the presentation in previously called endemic countries. Increasingly, they're recognising genital rash and rash without fever and spread beyond the rainforest to urban areas. More cases being seen in men than women, and previously, in contrast to earlier case reports of the predominance of children or young children, more cases were being seen in older adults. Many cases were unconfirmed, and this is part of the problem with diagnosis and reporting. They had seen 4 to 6 generations of transmission previously, but secondary cases were less common than we're seeing currently. Moving on for a bit more detail about symptoms and presentation. Symptoms, as mentioned, of monkeypox and smallpox are very similar. On this slide, I'm showing monkeypox pictures and characteristic rashes with early vesicles, pustules, umbilicated pustules, ulceration, crusting, and scabbing all being common presentations. It's common to see different lesions at multiple different stages in the one individual at one time. Notably, during the current outbreak, we've obviously seen an increase in oral and anogenital lesions. One of the biggest differences between monkeypox and smallpox has, of course, been the fatality rate, which was much higher in smallpox. And, of course, the lack of an animal reservoir, which is certainly something that's come to light with monkeypox as being a potential major barrier to efforts for control and for future spread. So this lines up monkeypox, chickenpox and smallpox. Chickenpox, of course, is not in the same genus, so it's not an orthopox virus, but also produces pox-like lesions. And the current thought variation in current presentations and some of the characteristics, including the location of the rash, perhaps the existence of a rash without prodrome, pain being predominant, secondary infections occurring, and encephalitis. What have we got in terms of recent reports to go on during the current outbreak? These consist of largely small sexual health clinic-based reports numbering 100 to 650, and the World Health Organization case report forms, which provide a wealth of information, but in a much more limited number of fields. So these are some of the reports we're just going to go through or compare to try to get a picture of the current clinical presentation that we're seeing at the moment. So just to orient you, these are their reports. This is the number of patients in each of them. The green is a report prior to the current, so it's the biggest previous reported case series of 122 from Nigerian outbreak prior to the current outbreak. The Thornhill Report is a multi-country report many of you will have seen, published in the New England Journal last month, and consists of 528 patients, mostly from countries in Europe and North America. A couple of reports from sexual health clinics of over 100 patients, and the World Health Organization CRFs. So in terms of epidemiology, you can see the younger age, median age in the Nigerian outbreak reported, and very similar age in the other outbreak reports, sorry. They are largely consist of men, and in particular MSM, even in the World Health Organization reports, although a substantial number of women are found in a subset of those, numbering about 200. Smallpox vaccination in 18%, and I think a previous slide mentioned there is evidence of partial protection related to smallpox vaccination in the past, but incomplete. Sexual transmission predominates in all of these reports, and a pretty consistent number of people living with HIV are represented. This isn't mentioned in the Nigerian outbreak, but it is of note that 4 of 7 deaths in that outbreak were in people living with HIV who were not on antiretroviral therapy. Concurrent STIs have been reported and diagnosed in a number of the reports to date in this population. So clinical aspects and case profiles. The World Health Organization, as I mentioned, also presents and summarises case profiles excluding the group of men who have sex with men, which make up the large majority of the cases to date. So you can see here a lower number of HIV positive and a lower numbers of sexually transmitted, those attributable to sexual transmission. This shows a representation of the proportion of cases in MSM and the proportion of cases who are men over time. And this is the weeks of the report and the percentage of cases. An age-sex pyramid in total case numbers and the non-MSM case is represented here and looks somewhat similar. And here, data on transmission. So this is to do with a sexual encounter for the MSM group and non-MSM. And there are obviously provisos around the reporting of this data and what we can and can't know. In particular, they make the point that separating transmission via skin-to-skin contact during sex and transmission via bodily fluids is not possible at this stage. Skin-to-skin contact with lesions we know to be an important transmission route. However, we also now are aware that monkeypox virus has been isolated from semen and rectal samples from confirmed cases. And this has to do with the setting during which transmission occurred. And in particular, as many will have heard, there's been a predominance of party settings and large events determined by the size of the event. But we are also seeing some household transmission. What about symptoms themselves? So the incubation period here, mean of 13, medians of 7 or 8 days, quite common in the reports to date. A prodrome has been seen in around anywhere between sort of 40 to 60% of cases, and largely that consists of a fever, although other symptoms are also been reported, including myalgia, headache and sore throat. Lymphadenopathy is seen as part of the illness in a significant proportion in all the reports, although the World Health Organization report is notable here that suggests any lymphadenopathy in only 20%. And what about the lesions themselves? Well, this is the reports to date. Vesiculopustular, 100% or in the high 90s in most cases, with a range of different presentations, as we saw in the pictures previously. And the location of the rash, even prior to the current outbreak, this report from Nigeria, you can see that rash on the genitalia was also fairly common in 68% of cases, and a high proportion of anogenital rashes in the other reports. Although, again, the World Health Organization report has a lower proportion with that presentation, instead more commonly reporting systemic rashes. Oral and oropharyngeal reports of rashes are also very common, and here the complications with proctitis, anorectal pain, constipation being reported quite commonly, although again less commonly in the World Health Organization reports. Hospital admissions are less common, and the main reason for those is symptomatic relief in the case of severe pharyngitis or pain, and the administration of antibiotics for bacterial complications. 12 deaths altogether have been reported so far. Higher rates of death were seen in previous outbreaks, however, different settings which occurred in very different settings. These are some of the pictures from one of the reports showing lesions in a variety of different places, and there are plenty of these around. The oral lesions in particular seem to be causing lots of problems, and anal and rectal lesions also leading to problems, in particular with pain. Are there evolving patterns in symptomatology? Well, it's a bit hard to tell at this stage, and the difference in the nature of reports and the selection of cases being reported is part of the problem with trying to make an assessment of this. Hopefully it will become clearer over time with bigger case series from more diverse range of locations and patients. Two more things to mention on symptoms and clinical picture. So there has now been a few reports of asymptomatic monkeypox being reported. So monkeypox, as you'll be aware, sexually active MSM in particular are encouraged to have asymptomatic regular STI testing, and monkeypox testing has been added to that in some settings and has been detected. What the implications for this are on onward transmission is at the moment uncertain. Mentioned earlier 12 deaths. We don't know a whole lot about these. Certainly immunosuppression has played a role in some cases. Encephalitis has been discussed, but details of the cases are lacking at the moment. Briefly, diagnostic testing, sampling. It's recommended that this is done wearing PPE, droplet and contact precautions and splash precautions. A viral swab is recommended from one or more vesicles or ulcers in viral transport medium, and a throat swab may also be useful if there is a pharyngeal lesion, if there are atypical lesions, or in the absence of lesions or rash. The laboratory should be notified if a sample has been sent for monkeypox testing, and testing is by detection of viral DNA by PCR. Antigen and antibody detection methods may not be useful, as they don't distinguish between orthopox viruses and are not widely available here. Treatment, so I'm not going to spend much time on this. The disease, symptomatic infections are generally self-limited. Supportive management and treatment of complications is the mainstay. Antiviral therapy is a pretty specialised area at this stage, although notably in some of the reports around the world is used a lot more widely than these indications. We do have some Australian monkeypox treatment guidelines and the references at the bottom here. The main treatment that's being recommended is tecovirimat, which is an antiviral, also known as T-Pox, an orange and black capsule. It can also be given IV, and the dosing indications for different weight ranges are here. It's indicated, or Australian guidelines suggest it might be indicated in those at particularly high risk of severe disease, in which case it would be given early, those who have severe disease, and other sites that might constitute a specific or special hazard, such as in the eye. So the efficacy data behind tecovirimat, I think the main thing just to mention here, I've put up here some monkey data that was used in, it's gaining approval for use in the US. It's all in animals. There's no efficacy data available in humans. The approval is based on the animal rule that some of you will be familiar with. I'm not going to go into in detail. We do have safety data, and this was in a placebo-controlled trial where the drug was given for 359 healthy volunteer adults, with 90 receiving placebo, and clinically significant AEs were seen in some individuals at higher rates than placebo, but none of the rates were particularly high for any of these side effects, and it generally appears to be very well tolerated. The CDC is combining their experience of its use. It seems to be quite widely used, although of course in individual settings this depends quite a lot on availability. Other treatments, vaccinia immunoglobulin is also held in the National Medical Stockpile along with the tecovirimat in Australia, and may be used alone or in combination with antivirals for treatment of both treatment of the severe disease, or in those who cannot receive tecovirimat, and pregnancy is one situation where that's been mentioned. Other potential treatments are not recommended in the current Australian guidelines, and I won't go into those in detail. What about vaccinations? Well, this is a little bit contentious. There's a lot of demand for vaccinations from high-risk groups at the moment. This slide here is from the AIDS conference I previously referred to in Montreal. On the one hand, the World Health Organization were suggesting mass vaccination was not required nor recommended for monkeypox, and also suggesting that this should be done under clinical trial conditions. At the same time, the conference organisers had organised for pop-up vaccination booths to be available to attendees within the conference venue, and this was in Canada, where vaccine supply was not the problem. So it largely is depending on supply in the location at the moment. What are the vaccines? Well, in Australia at the moment, we do have limited supplies of a third-generation Genios vaccine, which is what is being recommended at the moment. There are lots of issues with the second-generation vaccine, with some significant side effects, although uncommon, and significant contraindications, as well as barriers to its administration, which requires percutaneous scarification. The third-generation vaccine is subcutaneous and usually has a 2-dose schedule, although at the moment we're only using a single dose, which has been found to be effective internationally. ATAGI recommended for vaccination can be found on their website, and at the moment, any high-risk contact or MSM thought to be at risk. Sex workers and immunisation providers who are administering the second-generation vaccine, or who might be. And just a final word of note here, people immunised, so breakthrough infections have been described, and this is from Montreal in Canada, again, where widespread vaccination is being undertaken. In summary, monkeypox epidemiology is changing, although probably has been changing for some time. Symptomatic infections are generally self-limited. Supportive management and treatment of complications is the mainstay. Antiviral therapy may be useful in some settings, in which case tecovirimat is the preferred agent. Vaccination may modify disease course. And what here, I think something we should all be asking is, what's the role for any clinical research in this, and how do we know whether any of the things that we're doing are working? Thanks.
Kasia, thank you. That was masterful. You've brought together an enormous amount of information for something that's clearly changing quite quickly. We'll take questions at the end of the 3 talks. The second talk is by Dr. Carissa Bonner from the University of Sydney. Carissa is a behavioural scientist who researches risk communication strategies, and her talk is about CoReCal, a COVID risk calculator. Have we got Carissa?
Yes, I am here. Thank you. So thank you for having me. I'm going to talk about something a little bit different today. around how we can better communicate risk, particularly around COVID vaccination. And as the Deputy Director of the Sydney Health Literacy Lab at the University of Sydney, I will also have a health literacy angle on this. So I'll explain what I mean by that throughout the talk. So I'd just like to acknowledge that the University of Sydney is on Gadigal land of the Eora Nation and pay my respect to elders past, present and emerging before I start. So we've been looking at the issue of risk communication during COVID from a health literacy lens. So health literacy is a combination of people's health literacy skills, so that's their ability to access, understand and act on information about their health. And that interacts with the health literacy environment, which is the information that they can actually find about the health issue. So this is challenging at the best of times, and COVID is certainly not the best of times because the health information is just constantly changing. So we have a problem where up to 59% of Australians have low health literacy, and up to 95% of health information is actually too complex for the average person to understand. So the problem is an interaction between the individual skills and the environment that we're providing to the average person not meeting those needs. So we've been looking at this issue in the context of COVID since the pandemic pretty much began in Australia. So we were able to start our research in April 2020 at the very start of the pandemic, and we've been tracking knowledge, attitudes and behaviours around COVID since that time. So in that first year, we ran a series of national surveys where we first started looking at issues around risk perception and health literacy. So for this talk, I'm just going to illustrate a few findings from this series of studies to just show why health literacy is important in risk communication, and then show some solutions to how we might better address health literacy needs. So I'm particularly going to be talking about some of our really early findings from April 2020 and a new nationally representative sample that we ran in November 2020 initially. So just to remind you that the context was very different when we first started this research. So back at the start of the pandemic, our very first finding was that people with low health literacy and people who spoke a language other than English had a range of potential risk factors for being more at risk of getting COVID and having severe effects from that because of not engaging in the right behaviours to protect themselves. So we had poorer understanding of COVID symptoms at that time, less ability to identify behaviours that could prevent infection. So at that time, the focus was on hygiene and also social distancing, less ability to find information about COVID that they could actually understand, and also more endorsement of misinformation beliefs around COVID specifically. So even back in April 2020, there was already conspiracy beliefs circulating online, and also just vaccination more generally. So at that time, we didn't have any vaccines. It was completely hypothetical whether we would ever get a COVID vaccination, but already we were seeing a link to health literacy. And that meant that people were rating things like social distancing as less important because they weren't getting access to the right information to explain why that might be important for them. So as well as basic knowledge gaps in that group, we also had issues around misinformation. So again, back in April 2020, but we tracked this over time, and the sort of conspiracy and misbeliefs that were circulating was changing all the time. So you might remember there was at one stage a conspiracy about 5G being the cause of COVID spreading. And those were the sort of things that were circulating at that time. And it wasn't so much about the vaccination that we are seeing more now. So back then, we again were able to see a link to education, different language needs, and in this case, we looked at digital health literacy because most of this misinformation was circulating through social media. And at this point, we also saw that lower perceived threat of COVID, so that's around the risk perception, was starting to be associated with more misinformation and less intentions to engage in prevention behaviours. So both risk perception and health literacy were emerging as really important factors in how people were responding to the pandemic. So at the time, we got quite a bit of media coverage on this idea that young men were more likely to believe in COVID myths. And I just wanted to point that out, that there are certain demographics where you need different approaches. Oops, that's skipping ahead. certain demographics will need different approaches to target risk communication. But actually our bigger finding in our actual paper was really around the health literacy needs. So again, from April, we started looking at this idea of vaccination, and at this time it was completely hypothetical. So we had some comparisons to actual vaccinations such as flu vaccines to try to give people, or try to get some sense about whether COVID vaccines were going to be similar or different in their response. So at that time, there was only about 5% of people saying that they wouldn't get a COVID vaccination, which has actually played out for the initial vaccine rollout. Or it was fairly close actually to what ended up happening in Australia. So it didn't seem like COVID vaccine refusal was going to be a huge issue, at least in this sample. But where that did occur, again, it was associated with lower health literacy and lower education. So we tracked this over time, and it slowly sort of crept up as the prospect of an actual vaccine became more real. So by November in 2020, we had about 12% of people saying they wouldn't get the COVID vaccination, which is quite a big jump from the initial under 5% figure that we got. And at this point in time, the issues were around risk perception. So in Australia, we hadn't had too many problems with COVID. Of course, we had all the lockdowns and everything affecting our lives, but there weren't many people in Australia who had personally experienced severe effects from COVID. So the perceived public health threat was very low compared to other countries such as the UK that already had quite high number of deaths. So because the risk perception was low and there were some emerging safety concerns about how quickly these vaccines were getting developed, that COVID sort of hesitancy around the vaccinations was starting to creep up. So back in 2020, we had a situation where low health literacy was associated with lower prevention intentions, misinformation was related to vaccine refusal, and perceived risk was associated with potential vaccine uptake. Then in 2021, we got the vaccine and then the issues became a bit different. So we had real issues around access during the rollout. It was constantly changing who was allowed what vaccine, and actual access to the vaccine through the booking systems and where you could get it actually was a big problem for people with low health literacy. So health literacy is not just about the understanding and the intentions, but also the physical access to healthcare. So 2021, the barriers started to shift a little bit. But we still had this problem of the environment not meeting the needs of the population. So we did an assessment of the reliable sources of COVID vaccination information across lots of different government organisations and also international organisations like the WHO. And we found that information about COVID vaccines was written at such a high level that you needed more than a high school level of education to actually understand it. And it just didn't match the people that we actually needed to reach with this information. So Australia was actually the worst of all the countries that we looked at, and the vaccination information was even worse than other information such as around physical distancing or masks. So although we now had a vaccine available, we weren't explaining it in a way that the average person could actually understand. At the same time, we had issues around not meeting language needs. So many people in Australia do not speak English as their first language. And early in the pandemic, we saw translations actually not even making sense around COVID rules and regulations. And when the vaccine came out, you had to book online, but there were no translations available. So again, health literacy became a barrier because unless you could understand these quite complicated online forms in English, you weren't actually able to even book in for a vaccination. So they have addressed this now. This is the current version where you can see there's a translation section, but it actually took quite a long time for that to be developed. So in 2021, the issues for health literacy became sort of more around how quickly things were changing, and there were some actual access issues that were quite confusing to the general population. The vaccination information was too complex for most people to understand, and translations were either unavailable or inaccurate in many cases, not in all cases. So in the second part of my talk, I'm going to talk about what some solutions are to this. Sorry, I'm not sure why it's skipping ahead. So I just wanted to show you in the first part why health literacy is important in the context of COVID and why risk perception also plays a role. And in the second part, I'm going to show how we can address this through making the health literacy environment more suitable for our population. So the very first thing that we can do is to simplify text to a grade 8 reading level. So here you can see this is a health literacy editing tool that my team developed, but there's lots of different readability calculators that you can just access freely online. And what this shows is that a piece of text developed by the Australian government is at far too high a reading level. So anywhere where you can see colour, that means it's written in a way that could be simplified. And on the right, you can see the readability is at grade 15. So this is very typical for consumer and patient health information that's put out by reliable sources, but it's not made accessible to the average person. The second thing we need to do is to use consistent terms and translations. So I just wanted to highlight some work by a colleague, Holly Seal, who really realised this language issue was a big problem. The translations weren't being done well. And so she put together a glossary of COVID vaccination explanations. So we ran that through our health literacy editing tool to make sure that the English version was as simple as possible. And it's now being translated into 29 different languages so that hopefully the information that puts out makes sense in all those languages. And the third thing is around communication of risk. So this is something that I've been working with the Coracle team for some time, and it's been a tool to address those communication issues. So there are actually international guidelines on how you should communicate risk in a way that patients can actually understand. I'm not going to go through all of this now. But at the time that we were doing the vaccination rollout, there was very little available that actually met these guidelines for communicating risk in a way that actually makes sense to people. So what we did see is things like this. So this was a sort of viral meme that went around, which was the A to Z of things more likely to kill you than the AstraZeneca vaccine. And that was around the time that the clotting condition arose, and it really reduced vaccine intentions at the time that that was first discovered. So we had some of the vaccination rollouts were halted in certain countries, and people were genuinely worried about this new rare but serious effect of the vaccination. So although these sort of risk communication images actually get a lot of attention, they don't meet best practice for how you actually communicate risk in a way that will help people make an informed decision. So what will happen with someone who's actually worried about this is they're going to focus on the very bottom where it says chance of death by the AZ jab. They're not going to be able to quickly compare those two numbers, 1 in 3,000 versus 1 in 1 million. Our brains are not very good at comparing those sort of figures. And it's just going to actually emphasize the problem rather than address it. So what can we do instead? This was some information put out by Atagi, which tried to provide a more balanced view on whether you should get the AstraZeneca vaccination depending on your age. And it was put out as justification for the changing age thresholds in eligibility. So I found this really useful at the time because we were actually needing to know these numbers for some of the research that we were doing. But as a risk communication tool, it still doesn't meet best practice. So the average person is not going to be able to actually understand how to read this table. They're going to see these words, blood clots, repeated, and it's again going to emphasize the problem rather than actually help people make a balanced choice because the average person is not going to be able to actually read the correct part of this to find the numbers that apply to them. So what we've been trying to do with the COVID risk calculator, so Coracle stands for COVID risk calculator, is we have an amazing team of GPs and epidemiologists and vaccine experts who have done all the epidemiological modelling behind this calculator. And my team has been trying to help with making sure it meets health literacy needs. So the first thing that it does is we have gone through and made sure that all the text meets a grade 8 reading level. So particularly where it's quite text heavy in the introduction bit. The second thing it does is to really narrow down all that complicated information to just the relevant numbers. So that's addressing the information overload issue, which can be a real problem for people with lower health literacy. So in this when you enter your age, your sex, your vaccination doses, and you can choose to change how many cases are in the community, and that will change the way the model works, or it defaults to a large number of cases at the moment. And what it does is it gives you just the numbers that are relevant to that particular person. So here you can see the chance of dying if you get COVID changes depending on how many doses of the vaccine you have. So at the bottom is the worst case scenario, where we've got chance of dying from COVID if you have not had any vaccinations. And it's using a bar graph format to visually show that every dose you get is going to reduce your risk. And using images is another way that we can help people with lower health literacy to comprehend these very rare or very small probabilities. And then it also puts those side effects of the vaccination into context. So in this case, we're looking at the Pfizer vaccine. So we're looking at myocarditis rather than the clotting condition as the main serious side effect. And it's being transparent about how likely that is, but also putting it into a relevant context. So at the bottom, you can see the chance of having myocarditis after actually having COVID is actually quite high on this graph. And it sort of puts that vaccination risk into some sort of relevant context so that you can make sense of it. So compared to choking on a hamburger, this is actually something that people can relate to and say, okay, well, I may get this thing from COVID. The chance of getting it from a vaccine is a lot less, but it's still there. So it's still being transparent about both the risks and benefits. And then finally, what we're working on next is whether we can use more interactive formats or animations to try to help people actually understand the scale of these probabilities that we're trying to convey. So this is an example from a media article, again, going back to the clotting risk. At that time, it was estimated at 1 in 2 million. That has changed now. But you can't actually even see it on here, but there's a tiny dot that is the person with the clotting condition, and it's that person out of 2 million dots. And when you look at this on a phone, you have to keep scrolling and scrolling to see how big that base rate is. So we're looking at whether we can do something like that to further support the Coracle tool to help people actually understand the order of magnitude when we talk about very, very small probabilities. So I'll finish there. In conclusion, health literacy needs are not being met in COVID communication, and this is actually still really important. So although Australia had very high vaccine uptake initially, it hasn't been sustained for boosters. So clear communication about both benefits and harms is still very important. And tools such as Coracle can be a way to provide more reliable and personalised information. And we're still in the process of adapting that to make sure that it meets health literacy needs. So if you are involved in any sort of patient communication around COVID, doing things like a grade 8 reading level, reducing information overload, and providing visual ways to explain the information is a really good way to start to better meet the health literacy needs of our population. So thank you very much.
Carissa, wonderful talk. Thank you. It's an understatement to say that it was remarkably clear. I guess that's your bread and butter. I'm sure there'll be lots of questions. Our third speaker is Dr. Alia Makajani, and Alia is a senior paediatric registrar at the Royal Children's Hospital. And Alia is going to talk to us about virtual reality headsets to distract children, particularly at-risk children who are fearful of needles and vaccination. Alia, thank you.
Thanks, Lou. Thanks for the introduction. And I'm here to discuss the current area of research of mine, which is looking into the space of paediatric needle phobia, with new and innovative strategies to aid children for their immunizations. So I'll be here first talking about the background of procedural pain and distraction in immunization, various techniques used for immunization in children, new applications of virtual reality with clinical programs specific for procedural preparation, also looking into the existing research in virtual reality already. I'll be covering the Immunisation Service at the Royal Children's Hospital, in particular, the Immunisation under Sedation Service. And I'll then focus some time on the current area of research, which is looking at virtual reality in this niche population of children, the ones that have the most challenge in achieving successful immunisation. And these are the children with severe needle phobia, as well as children with developmental disability, such as autism, ADHD, and intellectual disability. So a bit about the background. So pediatric needle pain has repetitively been identified as a priority, and it has greatly improved recently. The approach to pediatric procedural pain should integrate psychological, physical, and pharmacological elements to provide maximum support for these children in particular. Aiming to vaccinate children with extreme developmental or behavioural disorders may trigger physical aggression or combative behaviour, and it can be quite a challenge for the child themselves, but also the safety of the clinicians involved. And parents and clinicians want the child to have a positive immunisation to help for them to then complete their vaccination schedule. So what other strategies we use at the moment in paediatric immunisation? Well, first, and I guess most importantly, it's to create this positive experience. There is quite a lot of work around the COVID vaccine in young children and planning for them to receive the vaccination. And there's some good approaches and helpful strategies. But the first thing is to establish an immunisation plan. So that's when will they get their vaccine, who should be with them, what they would like to bring to the vaccination, and also tackling any issues around anxiety around needle, the immunisation itself. It's really important to not rush them or force them to be vaccinated just to get it done. What supports are there already for children that have got anxiety or needle phobia? For these children, it's even more critical to have an immunisation plan. The families can contact the disability liaison officer to provide other appropriate services that might be available. Again, not rushing or forcing a vaccination is important, and using distraction techniques, pain management, and or awake sedation where it's required. How do we provide advice for families about talking to their children about vaccination? So they should firstly address their own questions around vaccination and make sure that they've achieved or been able to understand and find the right information. It's important for them to put some time aside to listen to their child's concerns before they jump in and start answering the questions. Always for them to answer honestly and in an age-appropriate fashion. Important to let them children understand that they're not only protecting themselves but other people around them. To set clear expectations and empower the child where choices are available, such as which arm would you like the immunisation in, and then also to praise and reward the child for their bravery. So these are some of the strategies already being used to create positive experiences for the COVID-19 vaccination. You can see there's some take-home rewards like colouring books. Virtual reality is also being used in some of these hubs, and the Buzzy Bee, which you can see on the right, and I'll cover. So simple strategies include positioning. You can see with that top picture, the child is facing her parent. She's looking away from the immunisation. We know that sitting upright seating in any procedure for children over the age of 6 months is the least intimidating. Distraction coping strategies could include things like play therapy and music therapy, technology devices like phones and iPads, and vibration instruments like the Buzzy Bee you can see, but they have all had varying and mixed results depending on the child and the environment and the clinician using them. In infants, swaddle techniques and oral sucrose is effective. Skin preparation can be with vapor coolant sprays, but they have minimal benefit in reducing pain and anxiety. And topical anesthetics such as the EMLA and Angel creams, they have been shown to reduce pain and are effective. And finally, for the children who have severe needle phobia, anxiety disorders, developmental concerns. Conscious sedation is available in pediatric hospitals in the form of either nitrous oxide or midazolam, most often. And nitrous oxide providing that fast onset, fast offset conscious sedation, which is an anxiolytic, amnesic, and analgesic properties. Whereas with midazolam, the children will have anxiolytic and amnesic properties, but not analgesic. So what else can we do to create this positive experience? Well, this is the virtual reality headset that we're using at the moment in our research. It's reasonably lightweight. It attaches with rubber straps to the head and it can be adjusted according to the size of the head and shape. There's various programs on the headset, including an immersive diving experience, which you can see in some of those photos on the right side, where the child will be transported to an underwater world, swimming with fish, dolphins, seals. It has an audio recording in the background as well, which has mindfulness and breathing exercises. And the program can be slightly altered for different ages for young children, adolescents, and adults. So there has already been some research done in virtual reality in procedural pain space, and it was published in the Journal of Pediatrics in 2019. This study looked at the efficacy and safety of virtual reality in two common areas, which is the emergency department and outpatient pathology for children receiving venous needle procedures. These children were randomized either to virtual reality or standard of care, with the primary endpoint being a change from baseline in the child-rated FACES pain scale. In this study, there were a total of 254 participants, 123 in ED and 131 in pathology. However, there were only a very few patients that had severe needle phobia or developmental issues. So the results of this study, in the emergency department, there was no change from baseline with standard of care, but with the virtual reality group, this produced a significant reduction in pain. In pathology, both groups experienced an increase in their pain from baseline, but again, with the virtual reality group, this was significantly less than with standard of care. The study concluded that for children undergoing intravenous cannulation or venipuncture, virtual reality was efficacious and decreased pain. So having seen the impact of virtual reality in the general population of children, we wanted to know if it would have an effect on the children requiring significant other supports for immunization. So these are the children that utilize the immunization under Sedation Service that I'm going to discuss ahead just in the next few slides. This service exists for the pointy end of significant difficult immunization. So you can access this service by a referral from a general primary care provider or pediatrician. Following the referral and prior to the appointment, a nurse contacts the family to discuss details with the child's caregivers and parent, including previous immunization attempts and failures, and a collaborative discussion about the approach to the immunization in the clinic. The service was audited between 2012 and 2016 over 5 years. And in that time, there were 139 children and adolescents with 213 vaccination encounters. The majority of the diagnoses of children with diagnoses attending this clinic were of needle phobia, with almost 60% of children having that diagnosis, and 22.5% with autism spectrum disorder, 10% with anxiety disorders, and intellectual disability with 3%, and developmental disability with 5%. Sedation was mostly achieved with inhaled nitrous oxide as a sole agent in almost 55%, and midazolam was used as an adjunct therapy. Out of the 213 vaccination encounters, there were only 10 failed attempts at vaccination. So we were curious to see then in this particular subset of children receiving immunizations, whether there would be any additional benefit with adding virtual reality headsets to improve their experience or even reduce the need for sedation. So this brings me to my current area of research, which is pilot study looking at the feasibility and accessibility of virtual reality for immunisation in needlephobic neurotypical children and children with developmental disabilities. This study is the principal investigator is Associate Professor Margie Danchin at the Children's Hospital and MCRI. The population we're looking at is children aged 4 to 14. We're aiming to recruit 30 participants altogether, 15 in the neurotypical and 15 in the with developmental disabilities. These children are receiving immunisations either in the day medical unit or in the nurse drop-in centre in the immunisation clinic. The design of the study is with pre-immunisation surveys completed by the child caregiver as well as the child, as well as Wong-Baker pain scales and measuring pain, and child fear scales measuring anxiety prior and following the immunisation, as well as clinician survey, which is to assess the ease and use of the virtual reality and overall experience with immunisation, and a qualitative interview with the child and caregiver for their feedback on their immunisation experience and the possible benefits and also difficulties with the virtual reality. We have recruitment currently underway with 21 out of our 30 participants recruited already. The outcomes are looking at the feasibility, so whether the child actually puts the headset on at all, the time it requires for the child to be introduced to the headset by the clinician, and also the use of the headset with the nitrous oxide and whether that's too overcrowding on the face. Accessibility, looking at whether they keep the headset on and also if it impacts their experience and makes it a more positive one. So we haven't quite completed our recruitment yet, but we already have seen some trends in this space. So many children found the virtual reality headsets distracting and helpful in that early anticipatory phase of immunisation. So that's when they're sitting in the waiting room waiting for the nurse appointment, or when they've had their midazolam medication and they're waiting for the effects. With the virtual reality headset on, some children didn't notice the immunisation being given at all. Some children removed the VR during the immunisation to maintain control of their environment. But of these children, many of them still reported that they had an overall positive experience using the virtual reality. Some found that there was overcrowding on the face in combination with the nitrous oxide mask, but this was more in the neurotypical children that we've seen so far. And few of the children actually became more hypervigilant with the virtual reality on because they weren't able to see the environment and the perceived threat of the needle. So how do we think this is going to impact so far? Impact. We hope that this pilot study will influence and guide a study design for a randomized controlled trial in the future. We hope that it identifies the children that may benefit most from using virtual reality and the way that it's best applied. And with virtual reality doesn't require specific training or skill set or hospital level equipment. So perhaps the addition of virtual reality for distraction for children in the community setting may help to create a more positive immunisation experience, reduce the incidence of negative experiences or failures, and prevent the need for hospitalisation for conscious sedation. So I'll just make a few acknowledgements to Associate Prof Margie Danchin, who's my supervisor for this project, as well as Dr. Daryl Cheng and Dr. Evelyn Chan, whose research I mentioned as well in this talk. And I have no affiliations with Smiley Scope or conflict of interests.
A terrific, wonderful talk. We've now got time to discuss all three talks. And if there are questions, please post them. But I was going to start with Kasia, if Kasia's still online. Yes, Kasia, hi, you might need to unmute.
Yeah.
With monkeypox, where do you think we'll be in 12 months' time?
Oh, goodness. I stopped predicting things a long time ago, Lou, with all of these COVIDs taught us some lessons, I think. We've got a lot to learn. I would like to see us doing some good information gathering and clinical research so we're not always playing catch up. it's a little disappointing. I feel like there's some things we should have learnt, and some really good examples of really good ways of collecting information around the world that we could learn from. So, I mean, there's still time. So hopefully we'll be able to do that. In terms of whether we think this is going to be a sustained epidemic, it's hard to tell. I think the interesting thing about that is the potential for it to get into other animal populations outside of Africa potentially, and what that might mean. Because there's a lot of that around, and not a very good understanding of exactly how widespread the animal reservoir might be or might potentially be.
And when you say we've had opportunities to learn from other conditions, which ones were you thinking of?
Well, COVID in particular. There's a lot of places around the world that got out some good data very quickly because they had systems in place that enabled them to do that. And a lot of that was driven by collaboration and networks. And I think that's sort of the key to this, because single centre reports, as I was trying to present, give you really only a limited view, and their values therefore sort of limited. And I think a lot of what we've been seeing, the impressions of monkeypox, are driven from a few specific series. We need to kind of broaden our view a little bit to better understand things and use the resources that perhaps we've got available to us to help to give a broader global understanding of what this represents. Because I think there's already a lot that we could know from what's been happening in other settings that we're not as well across as we should be.
This is a question to you, and then to Carissa. But the fact that the group of people affected is different, at least the high risk group compared to, say, COVID. We're talking about a younger group of people. Does that have sort of different meanings and consequences in terms of how we promote the public health message?
I think it's a really challenging public health message to promote, and it's a challenging public health space that we're in. I don't have lots of answers, but I think trying to communicate openly and pass on messages that are accurate and not loaded is really important in this space. There's certainly lessons from COVID about fear and the way that that can drive messaging that are really important. And I think Carissa's talk has lots of relevant things that I can see there. I think it's quite concerning for a lot of us, the way some of the messaging has been so far.
Yep. What do you think, Carissa?
Yeah, I mean, I guess. Sorry, you go.
Oh, well, if we swap from COVID to monkeypox, do you see it as just another public health message that needs to be conveyed, or is it much more complicated than that?
Yeah, well, I think this one, you've got to be really careful about driving stigma in certain groups. And we saw that with the HIV/AIDS, and that also the fear approach can backfire. So yeah, this one, I think monkeypox is much more sensitive than COVID because it is affecting only certain groups, and there are sexual connotations that can be taken in potentially stigmatizing ways, depending on how you do the messaging. So I guess the key there is that you need to do better targeting with the communications. So when you've got a particular group that you're needing to target, even within something bigger like COVID that's affecting everyone, you still need targeting to reach different communities that have different information needs. So that would be, I guess, the first approach. And the second is for something that's a bit more sensitive or has a risk of stigmatization, you have to co-design the messages with the communities that you're trying to reach. So I didn't really talk about that in our talk, but that's sort of the direction we've gone with that group of sort of younger men who are finding information from online social media sources. You actually have to understand the platforms where they're getting their COVID information and work with those platforms or work with influencers on those platforms, because they're never going to listen to the 11 a.m. press conference with the chief health officer where we might get our reliable information from. So I guess just understanding who your target market is, it's kind of basic marketing in a way, but also involving those community members, and particularly people who've actually been affected by the disease, is really important to make sure that you're communicating in a way that can actually engage without stigmatizing.
And then sort of following on, are there differences in people's personalities or their cultural background of how they actually assess risk? Or is it one size?
Really good question.
Is it one size fits all?
It is not one size fits all, but it's also hard to sort of generalize across cultures. So I guess I can answer that in the context of some actual research that we've done for COVID. So in the surveys that I presented, we knew that we weren't representing communities with different language needs or different cultural beliefs very well in those kind of national mass recruitment surveys. So we actually ran another survey that was done in 10 languages, working with multicultural health services. So that was focused on Western Sydney just before the Delta outbreak. And there were really big differences. So some of the community groups in Western Sydney were really knowledgeable, really highly engaged, were definitely going to get vaccinated, like 90% intention. So they were actually more health literate on this topic than the general population, whereas other language groups, particularly ones where their language needs hadn't been met in the official information, the ones that were getting their information from overseas relatives and where their COVID context was really different, they had really different perceptions of risk because they were sort of seeing what was happening maybe in India or the UK or other countries, and it was completely different than here. So I don't know of research that sort of shows people from this cultural or language group always perceive risk in different ways. But in Australia, different community groups were getting their information from really different sources. And we know that COVID information was sort of spreading through social networks. So it really depended on the group, and you can't sort of lump them together very easily. You have to actually do that work of understanding each group and working out which ones have the most information needs and how to target that.
There's a psychological theory about how we deal with the knowledge that we're all going to die, and that we don't live in terror each day of our death foretold. It's called terror management theory, but when there are sort of major world events, it's known that people's behaviour changes, so they become more xenophobic, more withdrawn, more paranoid and so on. Have you got sort of any comparisons of risk assessment before COVID and since COVID? And do they appear to be different?
I don't know of any sort of nationally representative, like ongoing surveys that you could sort of say right before COVID it was like this, and right during COVID it was like this, but we could see changes over time within Australia. So definitely you saw before Delta, because we'd had such small outbreaks compared to most countries, and most people didn't know someone in Australia who'd even had COVID, let alone died from COVID, completely different than other countries. You saw the risk perception go down and down and down, and people stopped caring. And that was at the same time as the vaccination rollout really needed to get going. So we had that really slow start. And then when you got the Delta outbreak in Western Sydney, the vaccination rates there went higher than the general population, even though they had more of those health literacy barriers and lower intentions. So once it was here, once you have the risk right here, you know someone who's had COVID, you know someone in the hospital, it completely changes your psychology. And even if you had safety concerns, you just went and got your vaccination. So I guess we've seen it on a smaller level in Australia, but I'm not, across like decades, whether that's sort of changed as a result of big global events, I'm not sure.
Thank you. Alia, are you still there?
Yeah.
So I'm interested in your study. Does the attitude of the parent affect the child? And particularly if the parent's a bit nervous themselves about the vaccine, for example, they might be very relaxed about a measles vaccine, but not relaxed about a COVID vaccine. Is that transmitted to the child?
I think it's probably not affected the trial so much because these patients have been booked in for weeks or months for their vaccination. So that whatever their hesitancy before might have been addressed already, or they've dealt with that before they've made the booking. But definitely you can see when children are going for their immunisation, a family whose parent is coming in with all of that anxiety around the immunisation as well, that transfers straight across to the child. So you do see that a bit more.
And do you think virtual reality headsets could be used in adults? And I'm thinking of panic attacks. I'm thinking of people who've got sort of psychogenic breathlessness and so on. Or do you have to be a kid and sort of hooked on IT?
Do you know, it's funny you say that because we've had one of these devices in the ED. We were just using it to see if it was helpful. And actually the nurses and doctors had more fun using it than the children sometimes. So I think definitely it would be really good for adults. And within the programs, there is an adult setting. There's breathing exercises during as well. So for sure, I think it would make a big impact on even an adult, pain and anxiety scale.
I think there's probably already an equivalent. As a respiratory physician, I see psychogenic breathlessness, and I've often wondered about people who run with headphones on. And you assume they do it because running's boring and you want to listen to music, but it's very possible that the music's actually competing with the pain and breathlessness of running, and your brain can only process a certain number of inputs at any time. And people are intuitively using a form of electronic distraction like you're using with children.
Yeah, I think that's probably very well observed, yeah.
I could keep chatting to the three of you, for an hour, but I've just been given the wrap up. There aren't any other questions, although John Litt certainly agrees that a good primer in health literacy underpins everything we do in the clinics. But I'd like to thank Carissa, Kasia, and Aya for three wonderful talks. And I'd like to now also close the whole forum. Thank all the sponsors for their support, to thank our IT team for terrific support during the day, to thank the Immunisation Coalition team, including Susie, for everything they've done to make this possible. And finally, to thank all the speakers, and a special thanks to Robert Boy, who did a lot of chairing today. So, with all those announcements, it's now time to finish. Thanks, everyone.